I thought what I would do for the class here is take a minute to look into my crystal wizardry ball and look a little bit about what your future in medicine will look like. So first of all, based on massive demographic shifts that I'm going to talk about, there is zero chance that you will not have work to do. Also, unless you're going into pediatrics, you're all going to be geriatricians. So we are facing what's called the gray tsunami. In 2018, just 6 years ago, something happened on the planet Earth for the first time in the history of world evolution. More humans were over 64 than under 5. The number of Americans 65 years and older is projected to increase from 58 million to 82 million by 2050. This is a 47% increase, and 1 in 4 Americans will be over 65, which is the new 35. So, at the same time, our doctors are aging. Within the next decade, we're expecting more than 1/3 of currently active physicians to retire. So aging and population growth will continue to be primary drivers of increasing demand for doctors. In fact, the AAMC estimates we'll have an 84,000 physician shortage by 2050. We also know that age has incredible impact on health. So if there was a miracle of modern science and medicine today, and we eliminated all cancer deaths, how long would human lifespan increase? Only 3 to 4 years. The same thing if we eliminated all cardiovascular disease. And the reason for this is that with age, we break down our resilience to heal, to overcome disease. And so age is the primary risk factor for almost every disease, but in particular, Alzheimer's and neurodegeneration, idiopathic pulmonary fibrosis, almost all forms of cancer, cardiovascular disease, even frailty, which is the major risk factor for poor outcomes after surgery. Just consider neurodegeneration itself. Today, 7 million Americans are living with Alzheimer's. By 2050, we anticipate as many as 13 million Americans will have Alzheimer's. So how will this gray tsunami affect you and your lives? So not only will you have to understand geriatrics and the complexity of multi-system care, you're going to have to develop a very different care delivery model. This model is called an age-friendly healthcare system. This is going to provide greater reliance on home hospitals, age-friendly telemedicine and technologies. I mean, I already can't see that little Apple iPhone buttons. In this age-friendly system, you're going to work with interdisciplinary teams of nurses, pharmacists, physical therapists, PM&R, primary care doctors and specialists to really deliver the best possible care. You're also going to have to really understand not only what to do, but what not to do. And you have to assess how frailty and immobility will affect the outcome of your patients before surgery, before major procedures. Scientists and pharmaceutical companies, I'm sure our guest speaker is working on this right now, are already working on developing drugs that actually augment our resilience to the process of age itself. It turns out there's many biological factors that I know you all have studied. I'm not sure everybody else in the room has studied. Things like mitophagy and autophagy, the process that clears old organelles from the cells. Drugs that enhance that appear to extend age. DNA repair enzymes like telomerase. Telomerase mutations are a major risk factor for familial lung fibrosis. And the upregulation of the vital AMP kinase pathway. That's typically activated by exercise, weight loss, cold, and it appears central to the aging resilience. And there's drugs now in clinical trials like metformin and rapamycin targeting the activation of AMPK. So while my generation focused on lifespan, your generation is going to be focusing on health span. How can we optimize a long life free of disease, ending with a good death, with home support, free of pain, disability, and free of indignity? The second vision in my crystal ball Won't surprise you. It's the transformational and frankly scary impact of big data and artificial intelligence in the practice of medicine. Stunning advances in machine learning, natural language processing, and large language computation can generate communications and discovery based on the integration of vast data sets. The sum of all medical knowledge and the electronic healthcare record is now available to these systems to advance healthcare and potentially help you perform better as doctors in your future. So how does this affect you? Well, think about this. This is daunting. In 1980, medical knowledge doubled every 7 years. 30 years later, the doubling period was less than 75 days. What you learned in your first year of medical school in the Renaissance curriculum, congrats, is now 5% of all medical knowledge today. So you may have to go back to school to, so your future is going to include AI-based systems to access and collate these data riches and assist you in diagnosis, risk management, and population health. Right now, with the University of Maryland Medical System and our faculty, we're piloting with 50 physicians a new technology, an AI chat box. This is a partnership with Microsoft, OpenAI, and Nuance. And you turn on your smartphone, you set it down, and it records your patient conversation. So it's going to allow you to leave the keyboard, once again, establish that patient-physician relationship. But that system is going to write a note for you. It's going to, if you say, hey, Mr. Jones, do you need a renewal of that prescription? Do you want it from the same pharmacy you got it before? It will do that. It will do your coding, your billing. It will answer your inbox, and studies have already shown that the answers are better than our brief, terse, on-the-rush answers. Of course, you'll review those answers and hit the send button. And of course, that AI system's going to fight to make sure the insurance covers your work, and that AI system will fight the insurance company's AI system in a... So my final peek into the crystal ball reveals something that won't surprise you having lived through the COVID-19 pandemic. And that is we're in an overpopulated, highly connected, warming planet. These factors are driving zoonotic pandemics, antibiotic resistance, and political instability. The world's population is projected to reach 8.5 billion in 2030, 9.7 billion in 2050, and 10.4 billion in 2100. It's scary to think that penicillin was first used in the US in 1942 and saved a patient with beta hemolytic strep sepsis. And now 82 years later, it's rarely used, and we have multiple organisms that are resistant to nearly all antibiotics. In your lifetime, thinking back, you've lived through the H1N1 pandemic in 2009, the West Africa Ebola epidemic in 2014, SARS-CoV-1 in 2002, which made it all the way to Toronto. Of course, SARS-CoV-2 in 2019. And many of us in the room will remember the West Nile outbreak of 1999 and the anthrax biological attacks in 9/11. So as we look ahead in your career for 20 years, you will see more and more of these zoonotic infections, and your experiences through the COVID-19 pandemic will steel you for the next challenge. It's important to remember that as physicians, even as newly minted interns on the wards, you will be considered role models in what you say and do and act and how you show up. You will have to communicate what you've learned through the COVID-19 pandemic about the value of science and knowledge and compassion in controlling disease and fear and intolerance. As physician, you are committed to a future that will never be stable and always require as much or more from you than the generation before you. So I'll finish by putting aside my crystal ball and just for a minute thinking about what will never change. And one thing that I think will never change is the laying on of hands. The laying on of hands is an action that's referred to on numerous occasions in the Hebrew Bible to accompany the conferring of a blessing or authority. Later today, you are all going to take the Hippocratic Oath. In the 5th century BC, Hippocrates, the father of modern medicine, stated, "It is believed by experienced doctors that the heat which oozes out of the hand on being applied to the sick is highly salutary. It has often appeared, while I have been soothing my patients, as if there's a singular property in my hand to pull and draw away the affected parts of aches and diverse impurities, by laying my hand upon the place and extending my fingers towards it." This understanding is universal in medicine. The Navajo Indians leveraged the laying on of hands for religious healing. The San peoples of southern Africa use the laying on of hands as a healing practice. Their healers lay their hands on a sick person to draw the sickness out of them and into the healer, much as we do with mental health therapy. The healers felt that this was a difficult and painful process as they took on the pain and disease from their patient. And remember that the role of healing, the role of touch in healing, is not only confined to the patient. This is often more important for our patients' families during time of tragedy and death. One of the rites of the practice of medicine is the declaration of death. So late at night, you will be asked by your nursing teammates to declare a patient as dead. This is very stressful as an intern or a resident. You may have been involved with this already. It's never easy. It's not even easy for me 30 years later as an intensivist. You'll go to a patient's room. The family will be at the bedside, and they'll look at you expectantly. Oftentimes, the patient is still connected to the ECG leads, and there's a flat line. Sometimes, based on the stillness and the pallor of your patient, you'll know that they've died. But the patient's family is still going to look to you for confirmation. So I suggest you consider this ritual. Take out your stethoscope. It's one of the oldest tools and a potent symbol of medicine. And then you will lay on of hands. Place the stethoscope under the palm of your hand. Lay it across your patient's chest. Close your eyes and listen. I suggest you also feel the carotid artery, the femoral artery. And when you're sure there's no heartbeat, you'll look up at the patient's father, mother, child, brother, sister, and you'll say, "Your father's died. He's now at peace." And in that moment, there will be a break in tension and understanding of certainty. Regardless of how the patient looks or the monitor or the wall, they will know that their loved one has passed because you've listened with your stethoscope and you have laid on hands. There's then another opportunity to walk to the patient's families and reach out and put a hand on an arm or shoulder, and without saying a word, you break a barrier and you permit grief or an embrace. There's no need to say the right words, just the touch that opens our hearts to our shared human experience. So in conclusion, I want to remind you of something I said in my welcoming remarks, that you're crossing this privilege threshold. Whether you're ready for this or not, you are empowered with this sacred right to share in our patients and their families' lives, secrets, joys, and suffering on this wonderful journey from birth to death. You all are going to be leaders in academic medical centers confronting the seemingly insurmountable challenges that I see in this crystal ball. You're going to leverage tools that I could only have dreamed of at your age. The twin revolutions in computation and molecular biology, which span from artificial intelligence, population health delivered through the electronic healthcare record, RNA silencing and RNA vaccines, therapeutic antibodies, genetically engineered T cells targeting cancer, genetically modified transgenic organs, and CRISPR-Cas9-based gene editing, just to mention a few. But your greatest strength will always be your humanism, your shared vulnerability with your patients, your altruism, and your stethoscope. So congratulations, class of 2024.